Well, it's always nice to put a statement like this up first. There probably is never likely to ever be a cure. We get asked that a lot. Why not? Because, in essence, by the time we're seeing them like this, we've already got that, and it's never going to go back to this. And if you remember from yesterday, the strength of that interface relies upon that intricate architecture. So until we can, transplant a foot, replicate an entire horse, wouldn't that be nice? Got to get the spots just right. We're never going to be able to completely cure this problem. So we have to concentrate our efforts on prevention, preventing progression once they've already got early disease. And now that we know a little bit more about each of the types, we're starting to, this is starting to become more realistic for us. When the supporting limb laminitis, because we are starting to see how important limb load cycling is to getting the blood flowing through the foot, we are starting to concentrate our efforts on being able to monitor how many times they're doing that in these horses that are at risk, and then efforts to increase their limb load cycling is going to follow from that. Can we reduce support limb load, which we'll talk about through physical means or through pain management? Can we develop means to provide whole horse or individual limb weight relief? We'll get to that in a second. We've been using pedometers a lot in the research setting, just cheap human pedometers that we strap to horse legs. And unfortunately, they're not particularly accurate when you compare them to force plates, when you're measuring how many times horses are actually cycling their load from one limb to the other. They tend to really dramatically overestimate how many times they're doing that. But nowadays we have access to some really fantastic, fairly low-cost accelerometers that give us really a lot of information about movement of the limb in space. And these things, which are water resistant and somewhat shock resistant, retail for a couple of $100. And we're just starting to put these on horses and try to come up with some algorithms and some ways of monitoring how many times they're actually shifting their weight from one leg to the other. How could we actually promote load cycling? And the problem with walking exercise, obviously, in horses that have fractured legs or are very painful, is that they don't really want to do it. And usually the surgeon who's fixed the leg isn't very keen on them walking around too much. But anyone who's been in hospital and had limb surgery, a hip replacement, a knee replacement, will know that they often get you up quite quickly and force you out the door. And I think it is important in these equine patients that we do that to an extent. How else could we promote load cycling? Or how else could we improve blood flow in the static leg? And we've tried a lot of different things and tested them with the microdialysis system that I showed you guys yesterday to see if they improve energy balance and blood flow to that part of the foot. Things like static orthotics don't seem to help too much. And so we've moved on to try to develop some more dynamic orthotics. And this was a machine that SoftRide has built for us. And we have tested this, and we can do toe or heel elevation dynamically. It's pneumatic, and you can program it in all sorts of ways. It actually improved blood flow and glucose availability and energy balance in that sublamellar zone close to the bone, which I presume is probably reflective of sole blood flow. But it did not in our experiments improve lamellar blood flow. So we're looking at some other things. This is something Pat Riley actually has been involved in the design of. It's an actuator to expand the heels. So in the weight-bearing limb, this is one of the next things we're actually looking at this year. The other thing we really need to do is determine the relationship between limb load and perfusion in real standing horses. And I mentioned yesterday we've got some experiments planned with the robotic CT, and I hope next time I speak to you guys, I'm going to be able to offer more information about that. Slings traditionally have never been a great way to relieve weight off horses. They've been an all or nothing proposition. A horse either dangles from the sling, which they can't do for too long. They get bad pressure sores, or they wear it like a jacket and it's not particularly useful. But there are some new developments in sling technology, including this one out of Canada. There's a European sling as well that can take partial weight and this one in particular is exciting because it could do it intermittently. And a lot of what we've learned from those support limb experiments is that we don't need to take all their weight off. We just need to take partial weight, and we probably need to only do it intermittently. We are also working on another project to intermittently relieve partial weight on an individual limb, and again, I hope I'll have some more information about that for you next time. The other thing that I think are getting better with these supporting limb patients or horses that are at risk of supporting limb laminitis is improving pain management, not just with drugs, but regionally. So with constant, this horse actually has a constant rate infusion of local anesthetic running to the palmar nerves. And techniques like this, I think, are helping us. There's also new information about using epidural medications, which is way back in the back, the lower back of the horse. But if you fairly recently, people have discovered if you pump enough volume in there, you can push it right up and get forelimb pain relief with the right drugs, which is exciting. We have done some work with cooling feet for this form of the disease in clinical patients, but it can take so long to develop that it's very difficult and not particularly practical probably to cool for weeks to months. But one exciting thing about cooling, and this is something we haven't really published yet, is that when you cool horses' legs and you get the skin below about 7 degrees Celsius, this is the mechanical threshold, so this is how hard you have to push on them to get a reaction. It has a pain relieving, a numbing effect, even in the horse, that perhaps we can use to our advantage in some of these cases to help them put more weight on the other limb. One of the questions yesterday from Dr. Frank Riley was, what can we do from a shoeing perspective, from a foot support perspective for these horses that are at risk of that problem? And I don't think that there's a lot that we can do that we don't already do. The one thing I'd say is that I think being too over bold with frog and sole support can sometimes, in these horses that are just pushing a lot of weight constantly onto that support limb, it tends to lead to necrosis and death of the sole corium in a lot of those horses, and that's what we've seen clinically. So we backed off that a little bit in these horses. Otherwise, apart from the general principles that we all used, I think we're finding that a lot of these static orthotic measures are not really working for those horses. What about the sick ones? We spoke about the sick ones yesterday, and probably the key for them is cooling the feet. And there's now evidence from studies of horses this is a study of horses that had diarrhea across a couple of different hospitals, that if they're sick and you cool their feet, and this is just with fluid bags full of ice and cool them consistently, they're 10 times less likely to develop laminitis. And the key to that is that, we can fix a lot of these sick horses now. 98% survival if they don't founder, but if they do founder, only half of them survived in that study. And mostly it's because they're destined to go back to racing, like this guy, like Painter, who was in this category. And if they get laminitis, unfortunately a lot of them can't go back to their usage, even if it's not severe. How do we cool them? Unfortunately, again, it's not something that's particularly easy. We've looked at a lot of different methods. This is the one that we use experimentally a lot, where we cool them pretty much from the upper limb down, but it's a controlled situation. It's not, not a typical situation. A lot of these ice packs that fit, just around the foot aren't very effective at reducing temperature. You only get maybe 5 or 10 degrees Celsius drop. This is like a little baggie of ice around the coronet. Interestingly, just an old IV fluid bag like that, which was what was used in that study of the horses with the diarrhea, works really remarkably well. It's cheap. They tend to get a bit of rubbing around where you strap this on if you're doing it for a couple of days in a row, but it tends to be a fairly minor problem. Back a few years ago, we with Game Ready developed a system for horses that was fantastic, and you could just put them on it. It was dry. It even had this swivel thing. All the machinery was outside the stall. It was about $50,000. Nice and cheap. And then the financial crisis hit about a month later. And it totally got shelved. It's actually quite difficult to cool the feet properly. And when we first started working with Game Ready, and I know there's other companies like Zamar, and they think it's going to be fairly simple, but it was years of modification of their original product just to get the feet cold enough. The other thing, though, it's not all doom and gloom, because even the worst methods drop the temperature of the foot by at least 5 or 6 degrees. And a lot of the research that's done on cooling, on hypothermia as a therapeutic in human trials, is done on the whole body. They take the mouse and they essentially put it in the refrigerator. And they're only talking about 5 to 10 degrees Celsius below normal. So, even with the worst methods, you can achieve that. So, I think it may be worthwhile, even if you don't have access to the best stuff in a horse that's at risk. SoftRide have actually also started to make, I don't work for SoftRide, but they have bought me a couple of steaks in a couple of different nice steak restaurants over the years, so that's my declaration. But I have helped them to try and design some of these boots, and this one actually works reasonably well, but over time it can be difficult to maintain in horses. It's a bit of work to maintain, so I think it's still a work in progress, but it's probably the best thing out there at the moment, and it does achieve really good temperatures, so the SoftRide ice boot I think is good. In people, we are much less tolerant of that sort of cold, and over time it's common with less than 5 degrees Celsius, with close to freezing temperatures applied, that you get frostbite. And occasionally you see this in horses. This was actually a horse that was cooled for about 5 days at New Bolton Centre. And I think this is a very rare occurrence, but it's something to be aware of when we're icing legs for days at a time, that it's possible to get adverse reactions. I think this is more likely to happen when ice is used in this type of boot, and the water is free to drain out the bottom. The ice itself then is in direct contact with the leg with no water interface. And ice, it's freezing, it's 0 C or 32 degrees Fahrenheit, when it's melting. But when you get it out of the freezer, it's a lot colder than that. It's minus 20 or minus 30 Celsius at that point. So ice in direct contact with the leg without water mixed with it can lead to problems. So, horses that have sicknesses that make them prone to developing laminitis are good candidates for this. But what if lameness has already developed? And we asked ourselves this question, and this paper was published back in 2000. and 15. In these horses, we experimentally induced laminitis, and we waited until they had the first signs of mild foot lameness, and then that you would notice as an attending person. And then we cooled the one foot from then on, and we did not cool the other foot. And the uncooled feet, 4 of the 8 actually, it was complete separation. It was really dramatic. And we blocked these as well continuously, so they didn't feel anything. And this is from the same horse. So the cool feet, we really didn't expect this to work, particularly at all. When we did this experiment, we thought it was too late. But it shows you how dramatic the difference can be when you cool them, even after they develop lameness. What about cooling in other forms of the disease? Because this is the sick horse one. What about the insulin-mediated disease? Does it work in that? And that's another question that we commonly got asked. So we did that experiment actually in December. And we haven't looked at the microscopic tissues yet, but I can tell you that just looking at it visually and grossly and looking at the horses, that it looked like it had a very similar effect on that insulin, high insulin model as it has on the sick horse model. So, what that tells us is that it's also probably indicated in these horses that come off pasture or that having episodes of laminitis as a first aid therapy, even if you think it's more the insulin form of the disease. So speaking of the insulin form, what can we do for prevention? Really, we have to identify horses and ponies that are at risk before they founder, right? Which is not, that easy, but it requires the appropriate screening and then requires appropriate management from then on. And how is this happening? The Arabian, like them or don't like them, the Arabian people and the Arabian industry are really good at developing ways of identifying problems genetically and screening and then breeding out a lot of these issues. And there's already, this is a brand new study that's out, already a study showing that there is a gene that's linked to or a genetic marker of high insulin and increased propensity to develop laminitis. So, if we can identify these horses genetically, that helps us for that horse keep on top of it, but it also helps us potentially breed out these problems, which is, in the end, is probably the goal. How else do we manage it, in the meantime? If you're dealing with horses, if you own horses, if your client's horses is, warm blood, a Morgan, a saddlebred, a Mustang, they're prone to particularly insulin dysregulation, and it's best to test for that, and the best test is the oral sugar test, and that's where we starve them overnight, we give them some oral sugar, and we test their insulin response to that. And we can identify that horse, identify their propensity to have a problem, and then deal with it with medication or management. What about Cushing's disease? That's mostly in older horses, 10 or 15 years or more. If you're dealing with a horse and it's unclear why it's got a little bit of laminitis, even, you see this in jumping horses that are 11 or 12 years old, and they've got some mild lameness, and they've got a bit of, if maybe you've been dealing with their feet for a long time, you're starting to notice change. That's when this problem can hit them, and if it's not explainable in other ways, it's worth testing them for Cushing's disease. What is Cushing's disease? It's essentially this is a brain, and that's an abnormal pituitary gland there. It's essentially overactivation of a portion of the pituitary gland, which then activates the adrenal glands in turn, and they produce too much cortisol. And there's some other effects as well, but really it's the cortisol. Remember our pony from yesterday, that causes this more of this insulin resistance. The glucose comes up, the insulin comes up in response to that, and that's what affects the feet. So whether it's cortisol from the inside, which is what we see with Cushing's, or if it's cortisone that someone's steroid that someone's injected into joints, it's the same mechanism. And again, insulin is at the center of both of those. The consequences of that are that we get, most importantly, chronic laminitis and abscesses, and we get infections elsewhere, problems with regulating their temperature and sweating, a change in the way they appear. They often have some muscle wasting over the back and more of a pot-bellied appearance, but all of those things are more advanced. You can have none of those things. And classically, they get this hirsutism, so this long curly hair coat. But again, they don't need to have that. So, if you're looking at an athletic 11, 10-year-old sport horse that has none of those features but has a bit of mild foot change, it's worth suggesting that it could be tested for Cushing's, particularly if you feel like its feet are changing and you can't explain that. How do we test for Cushing's? The two tests we use now are just measuring the ACTH, which is produced by the pituitary, and we measure that in the blood. Or we do something known as a TRH stimulation test. So we give them a TRH, which is a drug, and then we measure the ACTH response to that. How do we treat these guys? I think the important thing to realize, and I've had this over and over again with the Farrier, particularly that I used to work with in Queensland, you can't fix their laminitis until their underlying endocrine disease is controlled. And if you take anything away from this lecture this afternoon, that's the only thing that I really want you to take away. You cannot fix their feet, you cannot improve them often if they've got an underlying Cushing's or insulin dysregulation problem. That needs to be addressed first. How do we treat metabolic syndrome? If they're fat, they need to lose weight, right? It's not rocket science. It's much more effective to control diet than it is to provide exercise, particularly if they're sore in the feet. How do we do that? I'm not a nutritionist, but restricted diet. It's hard from an owner compliance standpoint. It really is, and that is the most difficult thing to get past in these horses, is getting owners to actually participate in dietary restriction. With pasture, it gets really confusing, and you can control the hay, you can test it for sugar content, you can control the hard feed that you give them, and it can be exactly, 10% non-structural carbohydrate. The biggest variable tends to be the pasture, and that is usually what brings horses undone, even if they have a very tightly controlled diet in other ways. Probably the bottom line, because it gets complicated, avoid this pasture. Don't when it's frosted or stressed, or if it's in, if it's tropical grass or winter. It's difficult, and I can't remember any of it, to be honest. But the one principle that's probably important when you think about grass is it makes sugar by taking sunlight and using photosynthesis and storing sugar. And so, that most sugar is going to be in the grass at the end of a sunny period. So it's going to be at the end of the day, in the afternoon, early evening. That's when grass is going to have stored most of the non-structural carbohydrate. That's the time to avoid grazing it. So early morning or late evening, early morning is probably the best time to graze. What about drugs? You can help horses lose weight a little bit with thyroxine. Probably the drug that has made the most difference for us in managing horses that have insulin dysregulation is metformin. And metformin basically lowers the blood insulin, and it does it by acting locally in the gut. It's really good for those horses and ponies that aren't necessarily fat, but have a big insulin response to ingested sugar. And it does have to be given before mealtime or before turnout in a targeted way, because there's probably a window of opportunity where it'll work in these horses and ponies. But it can be a remarkable drug in some of these horses and ponies that are having problems with insulin dysregulation. Cushing's, Pergolide is the treatment of choice. Prasend is the brand name. It's effective. Probably one key area where we run into trouble is that vets in particular don't realize that dosage needs to be adjusted. So, and typically what happens is the laminitis is getting worse, the Farrier is getting frustrated. No matter what you do, it's not getting better. And the horse is already on Prasend. What else can I do? Well, what you can do is retest the ACTH and adjust the dose, and often it needs to go up. And time again, I've seen where these horses just cannot do better. You cannot fix their feet, get them more sound, get them going better until their Cushing's is under control. Follow-up testing. And these horses need to stay on this drug for life. It's not a couple of months and then move on. What are some other general aspects of acute laminitis management? The pain is probably the biggest thing. This was a horse that had colitis, actually, back when I was a new graduate, 2001 it was. And he's on his way to the post-mortem room. And that was before we started cooling feet. Now we hardly ever see it in hospital environments. We used to see it in 1 in 4 horses at least that had colitis would see this as an outcome. Where does the pain come from? And that's a kind of a question that you wonder. There's some element. I know that writing's really small. Sorry. There's some element of pain coming from the actual lamellar tissue itself, and particularly early on in the disease. I think that the first pain is lamellar inflammation and tearing. Once the bone loses its suspensory, once the lamellae fail and the suspensory function's no longer there, a lot of the pain, and particularly in more chronic horses, comes from that crushing of the sole corium. Just not designed to withstand that pressure from the pedal bone. Interestingly, in more, probably in some of the newer cases, but particularly in the more chronic cases, a lot of the pain probably comes from the bone itself, and resorption of bone is a very painful thing. I'll talk about that a little bit more in a second. Then the pain gets transmitted through the spinal cord and up to the brain, and in a lot of these horses that have been affected for a long time, these pathways get kind of ramped up and overstimulated, and that also contributes to their pain. How can we assess pain? I always like to take a step back from horses and look from a distance. Typically in the horse it's worse in the forelimbs than the hind limbs. We get a posture like that. Horse that's evenly affected can look just splintered like that. Very rarely do you see a horse like that, but occasionally you do. This horse has hind foot laminitis that was chronic and not diagnosed as a problem, was presented for a neurologic evaluation. It's unusual, you don't see that very often. It can be difficult, though, to assess foot pain, and some of these horses, they're not necessarily painful on hoof testing. I like to apply a little bit of rotational force to the hoof capsule. You've got to be careful if they're really severe that you don't just rotate that right off. But obviously, but depending on how strong you are, if you've been to the gym, just go easy. But I think that can help you, particularly in hind feet, to establish if they're sore or not. And then nerve blocks, can obviously also help. It can vary a lot how, and body weight's a big factor in severity. I mean, this pony has equally severe radiographic change to that mare. This big guy actually has mild to moderate laminitis, but always most obvious on a turn on a hard surface, regardless of the animal. So when assessing lameness and looking at the effects, inside leg will really show up when it's laminitis related on a turn on a hard surface. And we use the Obel grade to grade them, but it's not a particularly good grading system, I've got to say. It is when they're acute and new, but not when they're a bit further advanced. So what do we do for first aid? Sure, pain relief and phenylbutazone, Banamine, pain relief. Mechanical foot support, confinement and restriction of activity, very important. And cooling, I think regardless of the cause, cooling the feet makes sense. A lot of different ways to provide frog and sole support. A lot of these boots now are convenient to drop dental impression material into. I really am a big fan of sand, much to the dismay of people who have to do the barn. Sand is just so hard to maintain in a state where it's going to be useful. Not just clean, but useful. It really does need to pack properly into the foot. It's such a fabulous surface because it allows them to, it eases breakover, it packs in and redistributes weight across the entire frog sole. It allows them to pivot without catching, which is a great feature, I think. So you don't get that rotational, torsional force on the capsule. Some horses don't like laying down, and a nice trick is, you can just bed half the stall in sand, particularly the half that they spend a lot of their time at the feed tub or at the water or at the window, and then they can lay down in the other half. I do use a bit of ace-promazine. We actually looked at ace-promazine to see whether it caused increased blood flow in the foot, because for years that's what we thought in it. In our microdialysis system, it did not, and in fact it had some pretty unusual effects on the metabolism in the foot. So I don't use it as a vasodilator, but I do use it to help keep them still. Once they've got laminitis, I think you don't want them to move around a lot. You really don't. How do we monitor them? These days, radiographically, I think the digital images are so good that we can now start looking at that lucent zone much more and compare that lucent zone. This horse has gotten a lot worse. It doesn't look a lot worse, I guess, if you're just looking from a distance, but when you look closely, the lucent zone is really increased in width, and we've got an increase in that founder distance there as well. The lucent zone is just that black area. It corresponds pretty roughly to the lamellae. You can't beat that measurement though, which is the extensor process to the level of the coronary band. That's king for acute laminitis. The problem is if you're just x-raying them for the first time, you really don't know where that started. So serial x-rays are really important. And I find hind feet can be really deceptive on x-ray. They're often not particularly severe. This horse had very severe laminitis and was put down for it in all 4 feet. It was a Potomac horse fever case. Once they start improving, I think the biggest mistake people make is they let them out. Number one thing that sets them backwards. I think 1 week for every day they were lame is reasonable. That's I don't know who started that many years ago, but I think it holds true. If they're lame for 5 days, then confine them for 5 weeks, because the tissue is not ready to take on the sort of loads, and you can't tell a horse just to kindly just walk around quietly for a couple of weeks, in the yard, don't do anything silly. If only we could do that, it would be nice. But it's a big thing as well. I think these days with Facebook, the owner says, "Oh yeah, confined, no problem. We'll keep it in the stall, for the 4 weeks, and then someone shows you some picture from Facebook of that. Oh, look, Misty's loving the paddock, and you're like, come on. I've blacked out for reasons of keeping identities hidden, but I think owner compliance, and we all know, can be really difficult. But if you stress things carefully, I think you can make some inroads. And I think with acute cases, we have to be a bit patient because they can take more than a week to improve. But if they're a couple of weeks and you're not seeing improvement, I think that prognosis is very grave at that point. We spoke yesterday about how it's irreversible, and we put that up in the first slide a little bit this morning. So I'd just like to address that point. So this was a 3-year-old Welsh pony gelding, and I saw this pony at the beginning of last year. It had a 5-day history of pasture-associated laminitis, only a young pony. It was skinny, it wasn't fat, it was in really nice condition. Its initial radiographs revealed that it had, a good 4 or 5 degrees at least of rotation in the fronts, and it was actually a little bit worse in the backs, probably a degree or 2 more in the hinds, which is unusual. So, you're already thinking, okay, this has been, this is a fairly significant episode for this pony. It had a really high, so that insulin after oral sugar should be less than 80, and it's about 500, right? So this is one of these ponies that makes a lot of insulin. It's not fat, but it makes a lot of insulin in response to ingested sugar. So we cooled its feet constantly for 5 days. We kept it confined, and then it went home. It had a very good owner who did everything that was asked. It was confined for 2 months. Its feeder management was changed, and we put it on metformin to control its insulin. And the neat thing about this, so we actually x-rayed it a month later, but these are the x-rays from 3 months later. And the neat thing about this is that, you guys could always rust the wall off and make it any angle that you want, right? And make things look better. But you can't, when you're looking at this lucent zone, I don't know how clear it is for a lot of you guys, but when you're looking at that lucent zone and basing your measurements off that, you can't fake it. So this has gone from 5-6 plus degrees back to 0. Hard to explain, particularly when, it was always drummed into me by Chris Pollard. This was irreversible, we couldn't change it, But clearly when you get it early and you treat them aggressively and you provide them with the right amount of confinement, I think you can get good results. And this pony, I stay in contact with this woman. She's back in Australia and still doing really well, still on the metformin. They realise this pony's a time bomb with pasture in particular, so they're very careful. But I think if you catch it early, you can do well. So we know how these things get worse, particularly on the outside. Some of the mild things you see, we're talking about those early disease in sport horses. Some of the first things that you see are these the roughening of that dorsal aspect of P3 on X-ray, and you see that change in the morphology of the tip of P3. It turns into more like a little ski jump, and these are some of the earliest changes that you see even before you see rotation. Once they start to get 5 degrees, you're starting to worry about athletic potential. 10 degrees classically, we'd say that they're not likely to be athletes, but there are exceptions. And then, we're worried about life often at this point. We're definitely more worried about life at that point. But, some horses don't penetrate. They remodel and go towards making the slipper foot. One of the most important things that happens with these feet is those coronary papillae are no longer, this is the normal situation where they're nicely aligned and the hoof grows straight down. As soon as that bone is depressed within the hoof capsule, those papillae are no longer growing straight down along, and that's that contributes a lot to the differential growth rate that we see in the toe versus the heel, because it's growing around a U-turn, essentially. We definitely get vascular consequences from this too, so we tend to get compression up around that papilla area there, and we also get it more distally when we do venograms on these guys. And a lot of that distal compression sometimes is due to those terminal papillae also lose their orientation, and that can become almost like a keratomatous growth. It's even more impressive sometimes in 3 dimensions. This is just that same horse actually that we're just looking at the venograms of. This is kind of a CT venogram. Like we were talking about before, a lot of these horses have really remarkable bone pathology, and this is one thing we're starting to see using that standing CT, the standing robotic imaging at Penn. We're starting to see that, some of the things that you can't see on X-ray. This horse, its bone was eroded right into the vascular canal, into the terminal arch. The bone pathology, can be really, really remarkable, and it's probably not all just from pressure and pressure necrosis. It's probably also set off by nearby inflammation, signals coming from the lamellar tissue, coming from the lamellar wedge. And, it really turns into Swiss cheese and loses its density and loses its architecture. And in people, that is a very, very painful process in itself. So people with cancer or this complex regional pain syndrome, there's 2 areas where they get a lot of bone resorption like that, and they get pain along with it. And the interesting thing is, all the morphine and other powerful analgesic drugs in the world don't relieve the pain, and the only thing that relieves the pain in those horses is bisphosphonates, things like Tildren and Osphos, which is interesting to consider for us. So I think that's something we need to look at more in some of these more chronic cases. I feel a little bit silly talking about foot care, because I think most of the people in this room in chronic laminitis know a lot more than me. My experiences though, I'm a real traditionalist. I really like hard bar shoes applied correctly, and with just the basic principles. I think you can achieve some similar things, and you can achieve some really great unweighting or release of pressure in horses that have particular areas of pressure with clogs. This is Rob Sigafus used to make these custom boots for horses that were really fantastic. Surgical considerations, I think, are something only to deal with once horses are more stable. I have done a few coronary grooves in my time and have had reasonable success in helping horses grow a more normal dorsal wall. I like to refresh it as it comes down the foot and really come back every couple of weeks initially, because it's just remarkable how quickly that'll fill in with cap horn essentially and defeat the purpose. I used to be more involved in wall resections, not as much anymore. Particularly total resections, I think. This horse actually did survive. But it's a long road, and there's so many factors involved. I know a lot of people use wall resection and tenotomy to get improvements in the venogram appearance, and this is one that we had. Although I worry a lot about the loss of some of the contrast fill in the solar region in these horses, and I think they get compression necrosis if they've got too much frog and sole support. And I think you feel really nice because you can see the vascular contrast now, but I'm not convinced that in my hands it's helped a lot of these horses to have that. maggots are close to my heart. If you have horses that have a lot of a devitalized bone, you can send these little guys in. I don't know if you can see them from the back, but they get bigger and then they hatch out occasionally as actual flies, which they're not supposed to do. But the beauty of maggots is if you've got areas of necrotic or dead bone, they can really go in and clean it up, and they only eat the devitalized material. And you can leave a little window in the front of a hoof cast for the maggots to go in and out. You know, if I'm dealing with horses, this is the same guy that had the total hoof resection. I call people like Scott Morrison or Raoul Brass for help, to be honest. So I will reiterate, though, the importance of a strong relationship between vet and farrier. And, you know, this guy in particular, Craig Jones, he hates being photographed, will not face a camera. Fabulous farrier that I work with at Queensland, and had a real knack for just assessing a foot and deciding what it needed, regardless of of anything that I said. And I would just point him at a foot and he would just make it better. And I didn't always understand it, to be honest. But that's, there's a lot of art to farriery for sure. And I try and bring a little science along, but there's a lot of art to it. And I've been very thankful to work with guys like that and guys like Pat Riley as well. So thank you very much for inviting me this year to the conference, and I hope to see you again.